Very good afternoon, one and all. I will be talking about the bilateral idiopathic optic neuritis and acute acquired common isotropias. And I am going to report 3 unusual cases which are not reported till date in literature. As we all know, acute acquired common isotropia is characterized by sudden onset isotropia, which is usually more than 15% after, and usually age of onset is more than 1 year. It might be earlier as well. And deviation is, the difference of deviation between all cases is less than 6% after, and etiology may be functional or neurological. And hereby I'm going to report 3 unusual rare cases of acute acquired common dystropia in 3 boys who reported with, who came and became, after MRI neuroimaging, the final diagnosis was bilateral idiopathic optic neuritis as an associated neurological finding. A 9-year-old male has a history of onset of acute onset of inward deviation with blurring and mild diminution of vision in both eyes for 1 month. There was no significant history related to excessive near work, trauma, or mobile phone use. And family history and birth history was insignificant. Best corrected visual acuity was 6/9 and 6/6 with minimal refractive correction, and which cycloplegic refraction was done. And tear segment was within normal limit. Color vision was deranged, and contrast sensitivity was 1.65 on Pelly-Rapson chart. Pupil was ill-sustained, although normal in size. Extraocular movements were full and free. And on Husbach, there was 30 degree of esotropia. And prism bar test revealed 65 PD of esotropia. AC by ratio by gradient method was 3:1. Fundus was absolutely normal. And in our institute, we routinely do a neuroimaging in all acquired esotropias. And on MRI brain orbit with optic nerve cuts revealed significant toxicity of bilateral optic nerves with enhancement on contrast, which was suggestive of optic neuritis. And patient was referred to a pediatric neurologist, where CFS analysis and immunological workup was done, and everything was negative, which led to final diagnosis of bilateral idiopathic optic neuritis. Methylpred pulse therapy was given for 5 days, followed by oral steroid. And after resolution of this optic neuritis and taking clearance by pediatric neurologist, the squint surgery under general anesthesia was done. And the final alignment was patient was absolutely orthophoric, and he's maintaining alignment till last 1 year. The second case, again, it is boy, 8-year-old, having similar history. All parameters were almost similar. The prism bar cover test was 50 PD, AC by ratio was 4:1. MRI revealed bilateral optic neuritis. Again, same, VEP was significantly deranged. CSF and immunological investigations were normal. Patient underwent methylpred therapy. After 6 months of resolution, squint surgery was done. Patient is orthophoric and maintaining the alignment. And there is no recent onset of neurologic optic neuritis episode. Then again, the third case is 6-year-old, youngest one, again male. Similar history, and prism bar cover test revealed 60 PD of acquired esotropia. AC by ratio is 3:1. MRI revealed bilateral toxicity and enhancement on contrast images. And fundus finding was, all 3 cases were absolutely fine. And then again, pulse therapy was given, and after resolution, the squint surgery under general anesthesia was done, and patient is maintaining the alignment. So, as of now, all reported cases of acute acquired comitant esotropias, neurological associations are astrocytoma, medulloblastoma, tumors of brainstem, cerebellum, chiari malformation, cerebral astrocytoma, etc. Our experience is different from others, as we have bilateral idiopathic optic neuritis, which is not reported till now. And the unusual cases all were boys between age 6 to 9 years, and a similar history was there. There was no history of excessive near work or mobile phone use, and all of them were diagnosed on neuroimaging only. They complained only of blurring of vision. The diminution of vision was not very significant, and coincidentally, the patient was diagnosed to be having bilateral idiopathic optic neuritis. To conclude, most cases of acute acquired comedystropia result from disruption of binocular function on vision, psychological stress, hypermetropia, or myopia. And to best of our knowledge, this is first report. And we recommend neuroimaging in all cases of acute acquired comitant isotropias, and multidisciplinary approach is recommended involving neurologists, neurosurgeons, and ophthalmologists to manage these cases. Thank you. Yes, ma'am. This is the previous orthophoric recent, and after within one month back, patient was ortho, and the same age, similar age, esotropia was there. Yes, inferior oblique overaction was there.
So what are the 3 points for inferior oblique to do in surgery? Like 3 methods are there, no? And you have done 12. So what are 8, 10, 12? Like?
So I have done by modified Elliott-Nanking method. So She's method is there, and then Fink method is there. Then Elliott-Nanking method, and recently Apton-Call method has also been described. So I have taken from IR, that is Elliott.
IO overaction was accidentally related with that?
Sir, this patient, IO overaction was there when, and it was significant. 9 gauge photograph mein itna pata nahi chal raha, but it was significant. FDT was strongly positive. And the thing is,
We are discussing the issue.
FDT was positive.
Well, you have done for this?
FDT for what?
For what?
Inferior oblique.
What for FDT you have done? Is it a restrictive strabismus case?
No, ma'am, long acting overaction can lead to, it was in not strongly positive, but it was positive. And after doing 12,
Okay, leave it, Dr. Anupam.
Yes, sir.
What was the total duration in which you have found these much cases?
Sir, total duration of what?
ये जो 12 केस तुम्हें मिले हैं
12 नहीं सर, 3 ही मिले हैं.
3 मिले हैं
हाँ.
तो कितने ड्यूरेशन में मिले हैं?
सर ओवर लास्ट 3 years में ये मिले हैं.
Different times you have operated. What
Yes,
is the
sir.
indication of surgery in these cases?
Sir, patient,
For some time with the steroid and all that? Or
sir, we wait, नहीं sir, acute acquired comitant dystropia, we wait for 6 months at least, as these patients have tendency, and all of them were advised alternate patching and
6
refractive.
months.
Yes, sir. Alternate patching was advised. The patient did not.
Did you need a medical treatment?
So in between, MRI revealed these things, not bilateral.
Not the treatment. Have you done any from the medical point of view? Before doing the surgery, have you tried something?
Sir, refractive, from ophthalmology point of view, sir, we advise refractive correction and alternate patching only. And
Spasm of the muscle, na? Basically. Anyway. Yeah. Any question?
Like how do you grade RAPD? You have mentioned L sustain and all of them.
yeah, RAPD in early stage, RAPD was not there. Pupillary reaction was ill-sustained. It is a form of early RAPD. When the ill-sustained reaction is when we suggest them when we put light, people constrict, but constriction is not maintained. Then RAPD grade 1 is when we move the light from normal to abnormal eye. But RAPD could not be present because, ma'am, the condition is, we cannot comment because condition is bilateral. RAPD may we are comparing with the other eye. And that grade 1 RAPD is when we move the light, people constricts but dilates immediately. Grade 2 may pupil constriction is delayed. Grade 3 may pupil does not constrict on putting the light, it dilates. And grade 4 is pupil remains dilated all time.
एक चीज और बता दो.
Yes, sir.
Neuritis कैसे relate करके उससे?
सर नहीं है रिलेटेड, नहीं है. अभी एक्सप्लोर किया है एंड स्टिल आई एम सर्चिंग फॉर लिटरेचर. अभी तक कोई पेशेंट ऐसा रिपोर्टेड नहीं.
Thank you.